Hey everyone, and welcome. If you've got exams on the horizon, you are in exactly the right place. Today, we're going to tackle lymphatic filariasis, and my goal here is to just break this down into a super high-yield explainer for you, packed with all the key facts and memory tricks that you're going to need to absolutely nail this topic. So let's get right into it.
All right, let's kick things off with a classic clinical scenario. You know, the kind of thing you'd see in your practicals or your theory papers. So, picture this. A patient, they've got a high-grade fever, chills, and a really swollen, painful limb. Just keep this case in the back of your mind as we go through everything, because I promise, by the end of this, you'll know exactly what's going on and how to manage it.
So, here's our roadmap for today. We're going to start with the parasite itself, then we'll follow its crazy life journey. After that, we'll look at the clinical signs it causes, nail the diagnosis, cover treatment, and then we'll wrap it all up with a rapid-fire revision slide. It's a really logical flow designed to build your knowledge step by step.
Okay, first up, the parasitic puzzle. Before we can even think about solving our clinical case, we need to get the fundamentals down. We got to understand the disease and, identify the main culprit behind it all.
Okay, first, the definition. If you need a perfect one-liner for your exam, this is it. Lymphatic filariasis is a parasitic disease. It's spread by a vector, think mosquitoes, and the adult worms set up shop in the lymphatic system. That is the core concept you have to remember. Worms blocking the lymphatics, which leads to that classic, really intense swell.
So who are these troublemakers? Well, they're filarial nematodes. And here is your first super important exam mnemonic to remember the main ones. Just think big white worms. The W is for Wuchereria bancrofti, and this is the big one, causing over 90% of cases around the world. And the two B's stand for Brugia malayi and the much rarer Brugia tumori. See? Easy.
Now, this is pure gold. It lays out all the high-yield differences your examiners just love to ask about. For W. bancrofti, think global, and think of the Culex mosquito. For B. malayi, think more Southeast Asia and the Mansonia mosquito. But really, pay close attention to that last row. The shape of the Microfilaria's tail is a classic differentiator in the lab. We'll come back to that for sure.
All right, moving on, let's see how this parasite actually operates. We know who it is, now we're going to track its journey inside the body and see how it causes all that damage.
Let's break this seemingly complex life cycle down into 5 really simple steps. So it all starts when a mosquito bites someone and injects these infective L3 larvae. These guys then migrate into our lymphatics and grow up into adult worms. The adults then produce tiny L1 larvae, called Microfilaria, that starts circulating in the blood. Then another mosquito comes along, bites the person, and picks these up. Inside the mosquito, they develop back into that infective L3 stage, and boom, the cycle continues. So basically, humans are the definitive host, and the poor mosquito is just the intermediate host.
Now for an absolute gem of a mnemonic. Seriously, write this one down. How do you remember which larval stage is which? It's simple. First rank gets MD. The L1, or Eft, stage larva is the Microfilaria, which is the diagnostic form you look for in the blood. And for the other key stage, just remember L3 is the infective form. L1 is diagnostic, L3 is infective. Nailing this is a guaranteed point score on any exam.
Okay, now this is super important to understand. The real damage, it's not just the worm itself, but it's our body's reaction to it. The host's inflammatory response, especially to dead and decaying adult worms, is what leads to all that scarring, that fibrosis, and ultimately the blockage of the lymphatic vessels. And a huge part of this reaction involves a little bacterium called Wolbachia. These bacteria actually live inside the worm, and when the worm dies, they get released and trigger this massive inflammatory cascade, making everything so much worse. This is a really key modern concept.
Okay, so now that we know how the damage happens, let's connect that back to what we actually see in our patients, like the one in our opening case.
Clinically, you're usually looking at 2 main stages. The acute phase, which perfectly matches our patient case, involves these recurrent episodes of really high fever and painful inflammation of the lymph nodes and the lymphatic vessels. Those are your key terms, lymphadenitis and lymphangitis. Now, the chronic phase, that develops over maybe 10 to 15 years and leads to those classic disfiguring signs like elephantiasis and hydrocele, which is actually the most common feature you'll see. Remember, early on the swelling is pitting and can be reversed, but later it becomes hard and irreversible.
Now, for a special condition you absolutely have to know, it's called tropical pulmonary eosinophilia, or TPE. You might also see it called occult or hidden filariasis. And it's a bit of a clinical paradox. The patient has symptoms, like a cough that's worse at night, weight loss, but when you look for the microfilaria in their blood, you can't find them. Why? Well, it's because they're being rapidly trapped and destroyed in the lungs, which triggers this huge hypersensitivity reaction right there.
So that patient from the beginning, how do we prove what we suspect is going on? Let's move on and look at the definitive laboratory tests that will confirm our diagnosis.
The gold standard, the absolute best test, is demonstrating the microfilaria on a peripheral blood smear. But, and this is the part you absolutely cannot forget, timing is everything. Because of the parasite's nocturnal periodicity, it comes out at night to match the mosquito's feeding time, you have to collect the blood sample between about 9 p.m. and 4 a.m. That's when you'll get the best yield. Now, if you can't do that, you can use something called the DEC provocation test, which basically forces the microfilaria out into the bloodstream during the day.
Okay, get ready for an absolute gift for your exams. This is a buzzword you've got to know. The filarial dance sign. It's a pathonomic sign, meaning if you see it, the diagnosis is made. On an ultrasound, usually of the scrotal lymphatics, you can literally see the live adult worms writhing and moving around. It's pretty wild. If you see this in a question, you know the answer.
Of course, we've got some more modern tools in our belt now. Antigen detection tests, like the Rapid Immunochromatographic Card Test, or ICT, are fantastic. It's super sensitive and specific for W. bancrofti, and the huge advantage is you can do it on a daytime blood sample. PCR is also an option, and you'll almost always see a major spike in eosinophils and high levels of IgE, especially in TPE.
All right, we've got our diagnosis. Now what do we do about it? Let's talk about the plan. We need to look at both treating the individual patient and, preventing the spread in the whole community. Okay, let's break down the treatment. The number one drug you have to remember is Diethylcarbamazine, or DEC. This is the drug of choice. It kills the microfilaria and, a bit more slowly, the adult worms. We often use it in combination with albendazole. But what's really clever is using doxycycline. Remember those Wolbachia bacteria living inside the worms? Well, doxycycline targets them, which basically sterilizes the adult female worms and eventually kills them. It's a pretty brilliant strategy. Now let's zoom out. How do we stop this on a massive scale? The key strategy is something called mass drug administration, or MDA. The global goal is literally to eliminate lymphatic filariasis, or ELF. So what this involves is giving an annual single dose of medication, usually DEC plus albendazole, to every single person living in an at-risk area. This interrupts the transmission cycle and is the absolute cornerstone of control programs like India's Hatipan Mukh Bharat campaign. Wow, we've covered a lot of ground. So now, for the best part, your final exam quick revision. Think of this as your last-minute cram sheet with every single must-know fact all in one place.
Okay, let's lock this in nice and quick. Cause, W. bancrofti, spread by the Culex mosquito. Life cycle, L3 is infective, L1 is diagnostic. Remember, first rank gets MD. Pathology, it's all about the immune response to the worms and that Wolbachia bacteria. Clinical signs, acute is fever, chronic is Elephantiasis and hydrocele. Diagnosis, the gold standard is a night blood smear, and the key buzzword is the filarial dance sign. Treatment, DEC is the drug of choice. And prevention, mass drug administration. Got it? Perfect.
And finally, before we wrap up, I want to leave you with a little something to chew on. So we know that nocturnal periodicity is absolutely critical for diagnosis, right? But how could we use that same piece of biological data to design smarter, more effective public health strategies? Think about vector control, about timing. It's all about applying this knowledge beyond the textbook to solve real-world problems. Thanks so much for watching, and seriously, good luck with your exams.